All right. Welcome to Behind the Scenes at ThyCa. This is, you should never put the four of us on a panel. So this is what happens when you let the four of us with no chief resident be in charge of meetings. This is always a mistake. So I knew we should, whoever the youngest one is, I don't even know, maybe that's Mabel. So
No.
we should put her in charge. Well, welcome, and it's always a delight to be part of the ThyCa crowd. I know we all wish we could be there in person because we learned so much and enjoy the interactions, but this is going to be our next best thing. We're going to go ahead and get started. Today's hour-long session is really kind of new and novel and trying to figure out where we go. We're going to sort of look at, how do we pursue care for some of these small thyroid cancers? And we'll start with Dr. Haymart from University of Michigan, talking about sort of the ultimate minimalistic management, which is just watching. And then Dr. Mabel Ryder apparently has some love of alcohol with Dr. Hay, and the two of them have figured out a new way to use alcohol for nodules. And then Dr. Kuo has never seen a technique she thinks is too expensive. So we will move toward, that was totally unfair, I know, the radio frequency ablation. Okay, so I think we're starting with Megan. Let's get started. Dr. Haymart.
So thank you. It's really a pleasure to be here. For those of you who don't know me, I'm Megan Haymart. I'm a professor of medicine at the University of Michigan. I've been a longtime member of the ATA, and I'm a very big fan of ThyCa. And so I do recommend ThyCa for the majority of my patients with thyroid cancer. And so today I'm going to talk about active surveillance of thyroid cancer. I have no conflict of interest to disclose. And during this talk, I'm going to focus on what is active surveillance, and then who is a candidate for active surveillance. And then finally, and probably the main focus of the talk, is what are the barriers to active surveillance? So just a brief definition. So this is from the National Cancer Institute. And so they define active surveillance as a treatment plan that involves closely watching a patient's condition, but not giving any treatment unless there are changes in test results that show the condition's getting worse. It may be used to avoid or delay treatments such as radiation therapy or surgery, which can cause side effects or problems. During active surveillance, certain extra tests are done on a regular schedule. And it can be used to treat certain types of cancers such as prostate, urethral, and melanoma. It's a type of expectant management. And so the key points here is one, this is a management option that's used in other cancers, not exclusively thyroid cancer. Two, it's used to avoid side effects or other problems secondary to surgery or other treatments. And then three, it doesn't mean do nothing. So it is a type of management, and it often involves certain tests done on a regular schedule. And active surveillance involves both the physician and the patient. So this is key. It should always be a shared decision. So who is a candidate for active surveillance? So most of the studies to date have been from Japan or Korea, with a few from the United States, with Dr. Tuttle involved in some of those studies. Most of these studies have focused on patients with papillary thyroid cancer, with tumor size less than or equal to 1 centimeter, and without any other high-risk features. So this is important. So these are individuals with very low-risk thyroid cancer. And some of these studies have suggested that older patients may be better candidates than younger. And so I'll show briefly some of this data. And so when we focus on tumors less than or equal to 1 centimeter, you can see that that's over 30% of all papillary thyroid cancers. So that could be a very large number who are eligible candidates for active surveillance. But the issue is that the ATA guideline actually recommends that you don't biopsy tumors under 1 centimeter. And so many of these patients, if the ATA guidelines were followed, wouldn't be candidates at all. They may not have their thyroid cancer diagnosed. But the key thing is the studies have focused on these very small cancers. The reason active surveillance has been considered at all is because we do know that 36% of patients who die from another cause will have an incidental discovery of a small thyroid cancer on thorough autopsy, meaning that this low-risk indolent disease is prevalent. These individuals went their whole life, never knew they had thyroid cancer, never had any problems. And so this suggests that there may be a subset of individuals who their thyroid cancer doesn't misbehave, it's just there, and doing additional treatments such as surgery has risk. And so since we know that, based on these thorough histology studies, it makes us wonder, are there individuals where less would be more. And this is a study from our colleagues in Japan. And so this is the issue related to age. So in this study, they followed patients for a median of 7 years. You can see they divided patients into less than 40, 40 to 59, and then greater than 60. They looked at size increase of 3 millimeters or more. So this is with ultrasound surveillance every 6 to 12 months. They looked to see if there's new lymph node metastasis. And then they looked to see if there's new clinical disease defined as the tumor reaching 12 millimeters or larger, or the appearance of new lymph node mets. And what they found is that younger individuals were more likely to have disease progression when they were followed with active surveillance than older individuals, suggesting that this indolent disease may be more common in older individuals versus some of these small tumors in young individuals may grow with time. And then this is very important. So this is sort of expert opinion by Brito and Tuttle and some of their colleagues, but looking at the fact that it isn't just about the tumor, it isn't just about the patient, but it's also about the medical team. And so ideal patients would be individuals who have a solitary thyroid nodule, well-defined margins, normal thyroid parenchyma, near the nodule. They don't want it next to the trachea. No evidence of extrathydal extension, previous ultrasound being stable, no lymph node mets, no distant mets. Best ideal characteristics would be older patients, those who are willing to accept active surveillance, those who understand that a surgical intervention may be necessary. So we do know from studies in prostate cancer that many individuals who start active surveillance do transition to surgery, either because of patient preference or if there's any sign of progression. These are thought to be ideal if they're individuals who will be compliant, have support of others, and then individuals who are more likely to die of other causes. So if they have life-threatening conditions, those are also ones who it may be safe just to follow their thyroid cancer. And then a key point of this is that your medical team matters too. So most of these patients are going to be followed with ultrasound. So it's important to have a multidisciplinary team, those who are confident using ultrasound, those who have a good follow-up strategy and a plan in regards to preventing loss to follow-up. And so these are expert opinions, but sort of looking at the full spectrum of the tumor, the patient, and the medical characteristics that would be important for following these patients. But active surveillance hasn't been shown to be widely used in the United States. So if you look at SEER data, it's actually less than 3% who have no surgery, and it isn't even clear if all of those individuals underwent active surveillance. So what are the barriers to its use? And so this is work by our team that's recently been published online. So we collaborated with SEER Georgia and Los Angeles. So SEER is Surveillance Epidemiology and End Results Program. And so this is thought to be the most comprehensive cancer statistic data set in the US. And we were able to have details on the patient's tumor and then also survey these patients. And then we asked the patients who is the surgeon and the endocrinologist who are involved in your care, and the patients identified them. We subsequently surveyed those surgeons and endocrinologists. So there are 448 surgeons and endocrinologists who provided care to patients in SEER Georgia, the entire state, or SEER Los Angeles County. About half the 448 were endocrinologists. Of the surgeons, about half were ENT and half were general surgeons. And we asked these individuals if active surveillance is an appropriate management option, and 76% said that it was appropriate, but only 44% reported using it in their practice. And so that brings up the issue is why is this occurring? And of those who reported that they used active surveillance, we asked which patients they'd be most likely to use it on. And for patients who had a tumor size that was less than 1 centimeter and they were 65 years old, of those that would use active surveillance, 70% said that would be a candidate. If the patient was 40 and had a tumor less than 1 centimeter, it went to 50%. If the patient's tumor was less than 2 centimeter, it was 32% and 30% for 65 and 40. So just showing that tumor size makes a difference, the patient's age makes a difference. And then why is there this discrepancy? Why are only 44% using it in their practice? And so we did ask about barriers to implementing active surveillance. And so I think these are very relevant to patients as well. So again, this was a physician survey, but many of the comments that I'm going to show are relevant to patients and physicians, especially in shared decision-making. So what we found is we asked the physicians in patients where it's clinically appropriate to use active surveillance, what are the barriers to using it? And so overwhelmingly, the majority said that the patient does not want it. So if it's a shared decision, if the patient truly doesn't want it, then of course there'd be no reason to proceed. Then there was this concern of loss to follow-up, which I think is a very valid concern. And even for myself, that's a major concern for me, because even our thyroid cancer patients who receive treatment, some of them move, some of them don't show up. So if someone has a cancer in their neck and suddenly they don't show up to clinic, that's a concern. We know from some of our prior studies that patients with thyroid cancer have a lot of worry. We also know that physicians recognize that worry. And so these physicians are concerned that active surveillance will lead to more patient worry. About 50% were concerned about malpractice lawsuit. There was also about 50% that were concerned about risk misclassified, meaning that they thought it was a low risk thyroid cancer, but maybe they missed a lymph node, which suddenly increased the risk of the patient, or there was some sort of characteristic that made this a higher risk patient than anticipated. It was also close to 50% that didn't know the length of follow-up necessary. So we do have data from studies, many of them that have a median of about 7 years follow-up. But what if it's a 40-year-old? How long do you follow that individual? Is 7 years enough, 10 years, 40 years? And so that was a concern. Everybody seems to be influenced by their colleagues, or many are, and so their colleagues not using it influence them. Some thought that there's really no clear optimal surveillance strategy. So we know it's been used in studies, but it isn't clear how to use that in the real world. Some don't have confidence in ultrasound for detecting progression. So this is our main method of follow-up, this ultrasound. And so, there has to be confidence that that doesn't pick up progression. Some don't have confidence in the tumor markers for active surveillance. This one's very valid. Normal thyroid tissue and thyroid cancer, makes thyroglobulin. Is the tumor marker helpful at all in active surveillance? And then you can see very few reported not enough time. And then it was only 5% that said it was never an appropriate management option. And then very few said less reimbursement. So the point here is that there's a lot of barriers to the use of active surveillance in the community. Some of these are relevant to patients, to physicians, to both. It's very few who think that it's never an appropriate management option, but there seems to be different thresholds in which individuals would be comfortable following these patients. So in summary, active surveillance may be acceptable for some patients with low-risk thyroid cancer. And the reason we believe this is that we know so many patients die of something else, have these small thyroid cancers, they never caused a problem. However, determining which patients are optimal, is still a point of discussion, and there seems to be different thresholds for different physicians. It doesn't appear to be widely implemented yet, and there are clear barriers that physicians mention. And so we need to address these existing barriers, including developing strategies to prevent loss to follow-up, reduce patient worry, and standardize long-term surveillance. And so I think that this is a very important topic. And as stated earlier, anyone who's interested in this topic as a patient should discuss that with their physician. It should be a shared discussion. And then as mentioned by Dr. Tuttle in his work, it is important, not only the patient, the tumor, but also the team that's following the patients. So thank you very much. And I look forward to my colleagues sharing their work as well.
Thank you very much, Dr. Haymart. That's a terrific overview, because I think now people are accepting that this is a good option for some people. It's just trying to figure out which people and what those barriers are. Absolutely terrific work helping us push this forward. Our next speaker is going to be Dr. Mabel Ryder. Mabel is an endocrinologist from the Mayo Clinic, who had been at our center at Memorial for many years with Dr. Fagan and I, and has now been at the Mayo Clinic. Mayo Clinic has pioneered alcohol ablation for lymph nodes, and now they've moved this to treatment of some appropriate nodules. And so we'll ask Dr. Ryder to share their experience and her thoughts on that. Mabel?
Thanks, Mike. I'm going to try and share my screen. Am I sharing my screen?
You are. Just go to presentation mode.
Yep.
There you go.
Perfect. Okay, thank you, everyone. Thank you, Mike, for that introduction. I've been very fortunate in my career to be followed by many giants in the field in thyroid cancer, and Mike, one of them. And as I came to Mayo Clinic, additional giants in the field, particularly Ian Hay, who I talked about in my last session for radioiodine, and now we'll talk about alcohol. And as I see the snow flying outside of my window, we look for anything in Rochester to warm us up, and alcohol seems to fit the purpose well. So today I'm going to be talking about ethanol ablation for recurrent metastatic lymph nodes and papillary thyroid cancer, differentiated thyroid cancer. It's such a privilege to be a part of my first ThyCa meeting. I have no disclosures. And so I want to just take a brief case-based approach and walk you through a patient that we see in our practice. This is a 54-year-old patient who had papillary thyroid cancer diagnosed 1 year prior. It was a papillary, 3.2 centimeters. 12 lymph nodes were positive. The largest was 2.7 centimeters. And after comprehensive surgery, 2 years later, he returns with new lymph nodes identified in the central and lateral neck. And this is just a cartoon, which we find helpful to share with our patients after their comprehensive neck ultrasound here in Rochester. The image, usually our ultrasounds here take about an hour, hour and a half, and after which we get these really nice cartoons, which is a lot easier to share with patients than sometimes those black and white images. And this shows that the patient has recurrence of suspicious lymph nodes here in the central neck. He's got a few nodes in the lateral neck on the left and a small node on the right. So this patient, we underwent ultrasound guided FNA of the right lateral, the left central, and the left lateral neck, and that's shown here. We biopsied the largest one here, a node here, and the node here, I believe. And they were all three positive for papillary thyroid cancer. And so this patient underwent reoperation of the right lateral neck, the left central neck, as well as the left lateral neck. And there were several lymph nodes that were positive from all of these compartments. The patient did well after surgery, and after annual surveillance 3 years later, his ultrasound shows a couple small lymph nodes in the left lateral neck, level 4, shown here. And this is the ultrasound cartoon. This is a classical image for a small recurrence in a lymph node. You see these tiny white specks, which we call microcalcifications. And when we find these in lymph nodes, especially in a patient with papillary thyroid cancer, it's consistent with a nodal recurrence. This was biopsied and found to be positive, again, for papillary thyroid cancer. So the question is, what are the options for the nodal recurrence in this patient? Could we use radioactive iodine? In this patient, and for local disease, and especially low volume disease, I don't tend to think of radioiodine. I think it's got limited benefit for local recurrences. We could do surveillance, and in disease that's in the lateral neck, particularly, lateral neck we call out to levels 3 and 4 and 2, surveillance for a short period is reasonable, especially if it's a low risk histology and other prognostic markers are reassuring. There's little harm from watching this over time and seeing what the disease will do, and many people can coexist with small nodal disease for years without requiring intervention. Certainly, we can take the patient back to a third surgery. Remember, the patient's already had reoperation comprehensively of lymph nodes. I have external beam radiation here, but it's not a typical at all approach we use for low volume nodal disease. And then finally, here in Rochester, we do have focal ablative therapy with ultrasound guided percutaneous ethanol ablation, or UPEA for short. In UPA, the best candidates for UPA are those with limited nodal recurrences. What we mean limited is by 1 or 2 lymph nodes that present, low risk histology, so classical papillary thyroid cancers. We favor smaller lymph nodes, so usually less than 2 centimeters, usually up to 1 centimeter is our ideal target for alcohol ablation. And our usual preference is that they've had comprehensive reoperation of that nodal compartment, whether it's the central or lateral neck, knowing that most of the disease has been removed and there's low risk for recurrence in the future after a comprehensive surgery. If a nodal recurrence then happens after comprehensive reoperation, it's often limited volume disease, meaning only 1 or 2 nodes, for which an alternative to surgery, such as alcohol ablation, is an ideal option. Alcohol ablation was first reported at the Mayo Clinic in 1991 in a patient with medullary thyroid cancer treated successfully, and then a few years later was used for the first patient with papillary thyroid cancer. And this again was led by Dr. Ian Hay, an interventional radiologist, Dr. Charbonneau, and Bob Lee, who Ian Hay worked really closely with. And over time, the first report of alcohol ablation is shown here, summarized by one of Bob Lee's slides showing 14 patients in the first report treated between 1993 and 2000. These patients were either not great surgical candidates, or they had declined surgery, or they were unresponsive to previous doses of I-131. All the ablated nodes decreased in size. 9 or 31% actually disappeared on ultrasound, and all decreased in volume at 1 and 2 years after treatment. Ian presented this work at a prior meeting in 2012 with a larger cohort of over 100 patients with what he called localized papillary thyroid cancer that confined to lymph nodes in the neck, with a median follow-up of about 5 years. Of the 164 ablated nodes, or of these patients, 164 had shrank in size, they became hypovascular, and even just under half disappeared over time on sonography. And these patients rarely needed repeat surgery for this disease. This is an example of a baseline lymph node with its vascularity that was seen pre-ablation, and then after alcohol ablation, we saw nice shrinkage in volume, as well as absence of blood flow, which is the blue and the red markings here. And this was observed at least 3 months after the UPEA. I had a nice video image of the actual procedure, but unfortunately I was not technically savvy enough. So Mike, don't leave me in charge of these things again. I couldn't get the video to work. So the actual technique is done really carefully by our interventional radiologist, and we have really two to three at most interventional radiologists that specialize in this procedure, and they use a slow injection of dehydrogenated ethanol. They actually first often give a test dose of local anesthetic, especially for disease in the central compartment, as that can paralyze it can be a sign that alcohol, if it leaks out, could injure the recurrent laryngeal nerve and lead to hoarseness. So a test dose of lidocaine is actually given first. If that causes hoarseness of the voice, then they would often abort the then procedure with ethanol. They tend to treat the deeper areas first, and they see these microbubbles that disperse throughout the node. And as they slowly inject, they reposition the needle as needed to treat the entire recurrence. They estimate the volume, and then they change the position of the needle over time, and the size is needed to disperse the alcohol, and they often overlap these micro bubbles for optimal coverage. They use very small needles, 25 and 27 gauge, and a 1 cc syringe. So this is actually literally tiny drops of alcohol that are instilled into the lymph node. They then look at the lymph node often the next day for residual blood flow. And here in Rochester, this is a 2-day procedure where they retreat the node on day 2. And so overall, this is very well tolerated. They do local anesthesia, which is usually sufficient to make this a little bit less comfortable. But, and it can, however, be uncomfortable as the alcohol sort of traces out of the needle. It can be sort of an irritant to the muscle and the skin, so it can be a bit uncomfortable during the procedure. These symptoms usually resolve once the procedure is over. There can sometimes be referred pain to the jaw, or to the ear, or to the tooth. And rare cases, there can be risk of nerve damage, but I've not seen a case in the 7+ years I've been here of permanent laryngeal nerve injury. And this is part because they've developed quite an expertise in doing this. But certainly recurrent laryngeal nerve injury can occur with hoarseness. When we see or observe hoarseness, it's usually transient, but it's important to understand that nerve damage can happen both to the recurrent laryngeal nerve as well as other sympathetic and other vagal nerves, as we call them, in the head and neck area that can lead to clinical symptoms. And referred pain is relatively common, but is transient. So follow-up, after a patient undergoes alcohol ablation, we repeat the ultrasound generally 3 to 6 months later. We track the recurrence in both by volume and vascularity, and at least 70% volume reduction and absence of blood flow is what we deem to be successful over time. If thyroglobulin levels are positive, we often see these trend downwards. And then importantly, we can retreat if we haven't achieved that volume reduction or the absence of a blood flow over time. So the same node can be retreated. And rarely, these patients need to return for surgery for that node over time. So the best candidates for alcohol ablation are low-risk histology, so the classical papillary thyroid cancers, the follicular variants, limited nodal recurrence, 1 or 2 lymph nodes alone, and small size. Generally, I say here less than 2 centimeters, but often 1 centimeter or less is our ideal candidate. And so before I kind of summarize, I do in our evolving approaches for surgical approaches for thyroid cancer, we have evolved to lobectomy. And in this space, we are now sometimes seeing localized limited recurrence in this setting. So this is a patient with who's a sonographer, and when she was doing sonography on herself, found this incidental thyroid nodule. It was about 1.2 centimeters, and it had grown slowly over time, over a year. So she underwent a lobectomy. There was fortunately no nodes involved at a baseline. And then 3 years later, she has an ultrasound that shows this suspicious appearing lymph node. And in hindsight, when we went back and looked at her ultrasounds very carefully through the cine images, this node is not enlarged, but it has white specks in it, which make it suspicious for thyroid cancer. And it is within a level 3 lymph node. So there's a dilemma now with this patient that we've taken for lobectomy alone. What do we do for this single small recurrent lymph node? Do we take her back for a completion thyroidectomy plus comprehensive neck dissection? Do we just pluck out this lymph node? We don't normally bury pick in thyroid cancer. Or can we treat this focally with alcohol ablation? And so, again, these are the options for this patient. And I presented her at a tumor board that we have every twice a month. There were probably as many opinions as there were endocrinologists and surgeons in the room. And we ultimately followed her for another 6 months to ensure we didn't identify new disease. And after seeing that she had nothing else developed, we had a comprehensive discussion, and the patient is currently seeking alcohol ablation for this node. And I will have to say that insurance coverage overall has gotten a little bit easier as this approach is now within NCCN guidelines as a reasonable consideration for patients. And so in summary, after our approach, after we select the right patient, patients undergo comprehensive ultrasound with lymph node mapping. We do require FNA proven disease. The patient then meets with endocrinology and often surgery to talk about surveillance, to talk about surgical approach, as well as alcohol ablation. And if they elect alcohol ablation, they have a consultation with interventional radiology, and then the UPA appointments are set up on 2 consecutive days, days 1 and 2. They return for follow-up 3 to 6 months later with a repeat ultrasound and blood work, and then noting that ablation can be repeated if needed for the same node, if targets were not met, or if 1 or 2 nodes develop in the future. And that's it. Thank you.
Fantastic. Thank you, Dr. Ryder. It's been really an interesting journey to see how the Mayo Clinic has developed that alcohol ablation over time. And in fact, we sent one of our radiologists to you guys to learn how to do it. So
Yeah.
after many years of me being reluctant, I've finally given up. You guys were probably right. And, there really is a role for that, which is amazing.
Yeah.
We'll now move on to our third speaker. I'll remind the audience, if there are questions and answers, please put them in the question and answer session. There's several good ones that have come up that we'll address after the next speaker. Our next speaker is Dr. Jennifer Kuo. Jennifer is one of the endocrine surgeons at Columbia here in New York with experience using radio frequency ablation, and she'll tell us about other thermal ablation techniques as well, understanding sort of what's their role in the management of thyroid cancers. Jennifer.
So thank you, Mike, for the introduction. And I just want to thank both ThyCa and Gary Bloom for inviting me to speak this morning on the different ablative techniques that we're using for our thyroid nodules. Okay, let's see here. So I do have one disclosure, and that is that I am one of the recipients of the 2020 ThyCa ATA Early Investigator Awards using RFA in thyroid cancer. So we all know thyroid nodules are very, very common in the population, found in about 65%, much more common in women, and certainly there's a higher incidence as you get older. And for many, many years, the mainstay of treatment has been thyroid surgery, both for malignant nodules as well as symptomatic, problematic, benign thyroid nodules. And although thyroid operations are generally pretty straightforward and associated with a low risk of surgical complications, there are some side effects that patients will often report after having undergone a thyroidectomy. And these include neck tension and tenderness, voice problems, even in the absence of a definitive nerve injury, swallowing issues, irritated windpipes. And of course, as surgeons, we focus on the very operation-specific side effects of a hematoma, hypoparathyroidism, or the much dreaded recurrent laryngeal nerve injury. In addition, even if patients undergo only removal of half of their thyroid gland, 25 to 30% of these patients will ultimately require some thyroid hormone supplementation in their lifetime. And even though at Columbia, we're especially proud of our small, tiny incisions, it nevertheless leaves a patient with a scar. And for a subset of our patient population, it is a big issue. And so for many years, patients have sought alternative treatments to an operation, especially for the management of benign thyroid nodules. And for many years, there really wasn't anything to offer them. But about 2 decades ago, various pioneers across the globe started to describe interventional ablative techniques that appear to have good outcomes in the treatment of thyroid nodules. And these include percutaneous ethanol ablation, as Dr. Ryder had discussed so eloquently in her previous discussion, as well as HIFU, laser ablation, and then radiofrequency and microwave ablation techniques. And so this will be the topic of the talk moving forward. HIFU sounds exactly what it is, high intensity focused ultrasound. This is a 6 millimeter ultrasound probe that is capable of delivering 3 millimeter sonographic pulses that is capable of delivering up to 120 watts of power. These very high intense sonographic waves cause cavitation of the underlying tumor tissue that ultimately necrosis and dies, and the body reabsorbs that tissue. Laser ablation is the use of crystal diode lasers, very, very thin fibers that have an operational power of about 2 to 4 watts. Each of these individual fibers can cause an area of necrosis of about 2 centimeters in diameter, and therefore for larger nodules, it may require the use of multiple diodes that are placed approximately 1 to 1.5 centimeters apart. It's important to note that laser ablation is a fixed application of energy, much like RFA and microwave ablation for other tumors that we've been using here in the United States, such as liver and bone. So you place under image guidance the diodes presumably into the center of the area that you would like to be ablated, and you program in how much power you'd like to deliver over however long of a time frame. And those diodes stay stationary in place for the duration of the ablation procedure. Over time, the tissue that has necrosed is again absorbed by the body. Of all of these modalities, radiofrequency ablation has been the most widely adopted internationally. This is the use of an electrical current that emits radiofrequency waves. And although people often think of this as a direct application of heat, it isn't actually. So the radiofrequency waves causes ionic agitation within the tumor tissue, and this causes frictional heat that then results in tissue coagulation and ultimately tissue destruction, which again is then slowly absorbed by the body. The appeal of radiofrequency ablation is that it gives you a wide range of power, especially when you're working with thyroid-specific generator systems. And this gives you greater flexibility in terms of the types and sizes of tumors that you can address. There are both advantages and disadvantages to the fact that RFA is subject to heat sink effect. And so this does provide some protection when you encounter fluid-filled structures like the carotid artery and the internal jugular vein, but also decreases the efficiency of your ablation adjacent to those areas. Finally, microwave ablation is very similar in concept to radiofrequency ablation, but it does use a different type of energy that uses electromagnetic waves. And this is a direct application of thermal heat to the tumor tissue. It operates at a much higher level of frequency in terms of the electrical current. But the greatest appeal with microwave ablation, especially when you're actually dealing with other types of tumors like liver tumors, is that it enables the delivery of very high power very quickly. And so it does cut down your ablation time. And unlike RFA, it's not subject, or it's less subject to a heat sink effect. And so it does work well in tissue with high water content. So I think it's important to note that RFA and microwave ablation are not, unlike laser, stationary fixed application of thermal injury, because the thyroid tumors are very, very small, and the neck is a very small space with lots of critical structures crammed in there with the thyroid gland. Even if you use low energy and appropriate electrodes with small ablation areas, the risk for thermal injury with the amount of energy that's being dispersed by RFA or microwave ablation is still high enough to cause thermal injury. And so there are some specific techniques to increase the safety of these procedures that have been described over the years that have been pretty much become the standard for how to perform these techniques safely. The first is the transisthmic approach. And this is really the concept of approaching nodules from the contralateral lobe going through the isthmus. And this allows for 3 different advantages. The first is that it increases the distance between your active tip and the skin. And so this helps to prevent cutaneous skin burns. The second is that utilizing this approach makes it a little bit more difficult to ablate in this zone here, which we call the danger triangle. And this is where the recurrent laryngeal nerve sits. It's not impossible, but it is, because these tend to be very stiff electrodes, a little bit more difficult to do. And then finally, by going through an additional amount of thyroid parenchyma or thyroid tissue, you do, the parenchyma actually helps to stabilize the movement of the electrode, which then becomes very, very popular, important in this next concept, which is the moving shot technique. So I already mentioned that even with the right equipment, the right generator, small amounts of power, if these electrodes stay in place, then stationary, there's still a very high risk of causing injury just due to the heat. And so for both RFA and microwave ablation, you have to utilize what's called the moving shot technique, which is basically advancing the electrode all the way to the contralateral aspect of the capsule, and then actively ablating as you're withdrawing the electrode towards the proximal capsule. So you do end up ablating in zones and in planes. And so you do have to start to think of these nodules in a very 3D fashion in order to plan how you're going to approach and ablate these nodules effectively. So these first 2 concepts are really all about safety, but we also have to concentrate on efficiency of our effectiveness of the ablation. And so it turns out that the vessels feeding thyroid nodules actually play a huge role in how effective your ablation can be. Just like in PEI, when you really want to see the loss of the vascular flow, the same is for these nodules. If you just ablate the vessel and you leave the thyroid tissue alone in the nodule, it turns out your nodule is going to shrink down anyway. So you just might not get enough to achieve the clinical outcome that you desire. Conversely, if you just ablate the thyroid parenchyma and you don't address the feeding vessels, you will leave the intentional rim of tissue that you have left to protect, like say, the recurrent laryngeal nerve. With the right vascular supply, you're going to have regrowth of that tissue. And it can be robust enough where ultimately it negates the volume reduction that you achieved with your ablation. So ablating the feeding vessels first, it becomes a very important concept for the ablation. And then finally, because we do know that the areas that we leave behind to protect certain structures are at higher risk for having marginal regrowth, there is the use of hydrodissection, which is a much more sophisticated technique. This involves percutaneous separate percutaneous needle that injects water because it has no ions and so cannot conduct additional electrical current like saline, and you inject water to create planes to increase your distance between your target tumor and your critical structure, such as the recurrent laryngeal nerve here, before you actually ablate. So these techniques, ablative techniques, have become pretty popular worldwide because they do offer some advantages over surgery. These include the fact that most of these ablative procedures are performed in a complete outpatient setting without the use of general anesthesia. So much better for the patient, but maybe not so much for the surgeon who's used to operating on patients who are completely asleep. They are obviously less invasive, associated with a shorter recovery time, and obviously there's no surgical scars. There's just a simple puncture that's barely larger than a regular needle used to draw blood. Probably the most appealing advantage for patients here in the United States is because we're only targeting the affected nodule and not any of the normal thyroid parenchyma surrounding the nodule, the risk for hypothyroidism and high thyroid hormone dependency after these procedures is almost zero. So when you look at all of these ablative techniques in summary, and I'm going to put in percutaneous ethanol ablation in there as well, really the only one that avoids a skin puncture is HIFU. There is a variable amount of power that's available with all of these modalities, and this does affect the flexibility in terms of which tumors you can address. In terms of what types of nodules are most amenable to these different technologies, most of them are going to be fine for any type of nodule, but PEI is actually much more appropriate for predominantly cystic nodules. And then 3 of these are fixed ablative techniques, whereas RFA and microwave ablation, it requires a moving shot technique. When you look at clinical outcomes and what patients can expect after these ablative procedures, most of the data currently involves the treatment of benign thyroid nodules. And pretty much the standardized accepted metric is the volume reduction ratio, or rate, VRR, at 12 months post-procedure. And you can see with all of these different modalities that we are achieving a pretty decent overall decrease in volume of the thyroid nodules that are treated. Now, although benign thyroid nodules are still the most widely accepted indication for these ablative procedures, it is quickly evolving. And so coming to print in Thyroid next month is the most recent systematic review and meta-analysis of utilizing these ablative therapies for the treatment of primary papillary microcarcinomas. All of these studies are out of Asia. 11 studies were included in this review, and they looked at laser ablation, microwave ablation, and RFA in about 719 patients in a total of just under 750 nodules. And basically what they found was that RFA is the most efficacious in terms of making the whole tumor disappear, but it does leave about 35% of patients where there's still residual tumor. However, when you look at the volume reduction ratio overall, they're able to achieve the same, if not better, VRRs than the treatment of benign thyroid nodules. Complication rates remained low. And all of the major complications in this review were actually nerve injuries, all 11 of them, and mostly due to microwave ablation because of the higher energy that's used here. And one of these voice injuries was permanent. There's also evidence that these ablative therapies may prove to be a very useful tool in our fight against recurrent cancers, just like percutaneous ethanol ablation. This was a systematic review and meta-analysis published in Thyroid back in 2016, looking at RFA and ethanol ablation. And what they found was that, again, they were able to achieve very similar VRRs of these tumors with both modalities, able to get complete disappearance of these recurrent cancers. In a lot of the patients, they did see a decrease in the serum thyroglobulin for most of the patients, and the recurrence and complication rates from these procedures remained quite low. And so there's good data to suggest that this may be a good option for these types of tumors as well. So in conclusion, these image-guided ablative techniques are safe alternative treatments for the benign, especially when you're talking about benign solid or cystic thyroid nodules, but there's increasing evidence that they may be a good option as well for small papillary microcarcinomas. And we do have some clinical trials. I know both at Mayo, at Sloan, at Columbia, and Hopkins for use of RFA on small papillary microcarcinomas. And it may also be a good option for treatment of recurrent papillary carcinomas, especially in patients who are no longer good surgical candidates. I must emphasize that the experience with these ablative technologies in the United States is extremely preliminary at this point in time, and therefore dedicated tracking of our outcomes is absolutely imperative to ensure that these technologies live up to their promising potential as alternative treatments to surgery. And then conceptually, these ablative therapies may seem very, very simple, but they're actually very nuanced to perform. And so, especially when you're talking about RFA or microwave ablation. And so specialized training is definitely required, even for those with very solid expertise in ultrasound and fine needle aspiration. There is a learning curve to these techniques. So with that, I'll end, and thanks for allowing me to be here.
Fantastic.
Hi, this is Angel. Just reminding everyone we have about 10 minutes of the formal time frame for the meeting, and then probably a good 8 minutes after that. There seem to be a lot of questions, so I'm suggesting that the doctors peruse through the questions and find the more pertinent ones that don't get as personal. Thank you.
I've got them. I didn't have anything to do while they were doing the hard work, so I was able to read through the questions. So I'll do a few of them here because we'll have till about 12:45. Megan, let's start with you. One of the questions had to do with, now that this transition from active surveillance to doing something, whether that's alcohol or whether that's lobectomy. Talk about, I know patients can make the decision, but when do we as physicians say, hey, it's time to stop watching? So what are the things that makes you think about that transition between active surveillance, even in people and doctors that want to, into doing a more active treatment?
So most of what we know so far is based on a series from Japan. So it is a different patient cohort. For those individuals, they would consider progression if it was 3 millimeter increase in size or more, if there were new lymph nodes, and then, if it was up to 1.2 centimeters. It's a little bit sort of arbitrary as far as where those cutoffs are, except for the lymph nodes. So I think for all physicians, once you see worrisome lymph nodes, that's a major red flag, and that would sort of kick individuals over. And then, I think the patient always factors in as well. So it's going to be the patient's comfort with being followed is going to make a difference too.
Yeah, and Mabel, there were several questions about sort of using your alcohol ablation around important structures. One said, can you use it for a lymph node hugging a nerve or a lymph node near the plexus? Can you talk about how careful you guys really are? I mean, I know you can get close to those things, but the reality is, what do you do with that?
So disease that's around nerves, especially the recurrent laryngeal nerve or in brachial plexus, the lidocaine helps that, but we would tend to shy away from disease that we think is really adherent to or invading the nerve. That's often high risk disease as well, maybe a high risk histology, and we don't tend to like alcohol ablation for things that are aggressive, higher risk thyroid cancers. So in the central compartment, we really like a lymph node, and we pay really close attention to that ultrasound, make sure that it's a well-defined. When I look at it, I make sure the lymph node looks well-defined. I like to see what looks like a capsule around the lymph node. And then I know that if the alcohol leaks out, there's probably little harm or risk other than some tissue irritation. But if I find that the disease, the patient has symptoms already of hoarseness from disease that's in that central neck, I don't think alcohol is the best candidate for that. And for more locally invasive disease that often is reflected in their initial histology in their course, I tend to favor surgery for that.
So Jenna, if we have to be a little careful about alcohol, you mentioned a little bit about hydrodissection, because honestly, most of the stuff we can fix with alcohol, I'm usually pretty comfortable watching anyway, because it's not in a worrisome location. It's not, but the ones that I'm worried about are near a trachea, near a nerve, where it's going to be challenging for you surgically. A surgery wouldn't be without risk. Can you talk a little bit about the balance of doing a surgery in that setting versus doing, what's still research setting, thyroid cancer, RFA, that sort of stuff with hydrodissection? Think a little bit about that for me.
Yeah, so I've actually have ablated a couple of recurrent cancers in the thyroid bed, and these are patients that have undergone 3 or 4 previous neck operations and just have indolent disease that just kind of keeps popping up. But one of the reasons why we are a little bit more aggressive in terms of intervening in the nodes that are in the central neck is because, yes, if they continue to grow, they have the potential to invade these critical structures. So if they're small enough and they're early enough where they're not stuck to the tissue, then you can utilize the hydrodissection. And I always count the few patients that I've counseled, I may or may not be able to do this. It really depends on if I can lift that lymph node up from where I know that nerve is going to be. And so they go into the procedure knowing that it may or may not be a successful one. But the couple of times that I've had to do it, I've been able to. The tricky thing about the water is that it actually gets reabsorbed pretty quickly. And so you may or may not have enough time between injecting the water and getting the ablation. So it does actually require a couple of extra hands to do it, but it is feasible and has worked well. The one time I wasn't able to lift the lymph node was actually previous lymph nodes I had ethanol ablated. And I was trying to just get the last residual part of it. And those were, quite scarred down onto the trachea. They weren't growing, but they were there.
You remember that one. Megan, we had a very good question about extending this concept of active surveillance. We had you talk about just the small cancers to begin with, but several questions that came up. These are people that have had total thyroidectomy, radioactive iodine, and low-level thyroglobulins, 0.5 or 1. Is there a framework that we talk about using the same active surveillance terminology of sort of watching and waiting? We often say observation, but is there any role sort of for watching those low-level TGs over time? It kind of feels like active surveillance that meets some of the definitions you talked about.
So I'm on the NCCN guidelines, and we decided not to call it active surveillance just to avoid confusion with sort of the active surveillance that we do for this low-risk thyroid cancer. But as endocrinologists, that's probably what we do the most, is we have a lot of individuals who have biochemical evidence of disease. They have a low level of thyroglobulin that's detectable. We may not see anything with neck ultrasound, even if we do additional imaging. And so we do follow those patients. And so for all of us who are endocrinologists, that's pretty routine. And that's just, we consider it part of the thyroid cancer management. We try to reassure the patients. We decided on the NCCN guidelines not to call it active surveillance, just so we could use that terminology specific to this very low risk setting of someone who hasn't underwent like an initial intervention.
Yeah, exactly. Yeah, so the concept is there, but we just chosen to keep our name for active surveillance so that we all know what we're talking about in that low risk initial setting. Mabel, from the big picture, it's always neat for us at big centers to talk about alcohol ablation or RFA at Columbia. I mean, honestly, how widespread are these techniques across the United States? Is this research at this point, or is it clinical and local? For the audience, is this something they're going to have access to outside of traveling to someplace?
Yeah. So I think certainly because it's becoming not research alone, and really as part of our standard of practice and standard of care, and allowing patients to avoid more expensive surgeries and reoperations, at least in our practice, as part of standard of care. And interestingly, the patient that I shared in my slides who had lobectomy, who wants to get ethanol ablation, her insurance has approved the procedure, but has not approved it at Mayo because it's out of network, and she's been recommended to get this at home. And so it is growing across centers, but it's still quite limited because a center has to have enough expertise in this disease and have a well-trained person, as Jennifer said, even for RFA, to develop this. And as you said, you sent one of your radiology experts here to Mayo, who spent, I think, a week here in probably the summer, I'm assuming, and got some expertise in this. So it does take time for this expertise to develop. And we have Bob Lee here, one or two radiologists who do this, and they're very skilled in that. And so that can be developed at under centers, but requires, like when we say for surgery, high volume surgeons, it probably needs a high volume interventionalist to also tackle this.
Yeah, I agree completely, Mabel. The person we sent up to you had 10 or 15 years of doing interventional radiology, and in a week she could figure out how to do it in thyroid. We weren't starting from scratch.
Yeah.
Jennifer, the ThyCa patients always think outside the box, and they always ask us stuff we can't answer. So that's part of my favorite part about being the moderator. So here's a tough question. They want to know, can you use any of those ablative techniques for lung mets or bone mets, or, why are we just focused on the neck? Is there any role for something like that in the distant metastasis setting?
Absolutely. I mean, for RFA currently in the United States, that's actually the accepted indication are liver tumors, bone tumors, and have been widely used for those applications for many, many, many years. That there's no controversy there. There's nice CPT codes that you can use, and so that technology does exist, and we're using them for that. All of these ablative techniques for thyroid nodules, however, here in the United States is quite new. And so you talked about accessibility for patients before. There's really like 10 centers currently in the US that are offering it. And there is no CPT code for RFA specifically for thyroid nodules. And so there is a battle with the insurers that we have not won yet and probably won't for a few years.
Yeah, and I think that's important, and it's okay for right now. I mean, I think now there's no question. We all agree these techniques can be done and they can be done safely. But now, who are the right patients to do it in? What are the contraindications? What's the sequence with surgery? And until we really figure that out, I mean, we don't want this rolled out over the entire world. So I think it's the place where we certainly have these techniques. It's the same with active surveillance. We know it's good, but to try to figure out. Let's finish in about 2 minutes, and I'll ask each one of you. If like somebody just woke up from the last hour's worth of talk, what's the one or two things you want them to remember from your presentation today, and then we'll quickly finish. Megan, go first.
So my summary for active surveillance is just that it's a shared decision. The patient and the physician should be involved. And I think that there's some great studies and trials that have been done, but there's still some implementation barriers that need to be addressed. And so you want to think about those as you talk about it with your physician.
Awesome, Megan. Mabel?
Yes, for low risk thyroid cancer recurrences, those little pesky lymph nodes that often plague us, and patients, in carefully selected patients with one or two lymph nodes, especially in the lateral neck, we have a nice alternative to standard of care surgery, which is alcohol ablation. And it can be done safely, and it's a nice alternative to surgery at least.
Perfect. Jennifer, finish this up.
So I agree with Megan in that, there are some promising interventional non-surgical ablative techniques coming down the line. But because there's very, very little data on the use of those on thyroid cancers and thyroid cancer recurrences, whether or not that is an appropriate option for you really depends on a thorough discussion with your provider, your physician, and really a multidisciplinary team.
Fantastic. Thank you, guys. There was a fantastic presentation, absolutely state-of-the-art and phenomenal presentation. I think it gives us a view where we are now, where we are going to be in the next few months, and then hopefully where we're going to be a few years down the road. Thanks very much for a wonderful presentation.